Our next speaker is Dr. Susan Debin, MD. She has been in private practice for nearly 25 years and continues to focus on preventive medicine with a holistic approach. Dr. Debin was educated at UC Berkeley, and she received her MD from Case Western Reserve University. She is certified by the American Board of Family Medicine. She has extensive clinical, research, and volunteer experience, is a member of the American Business Women's Association, is often called upon to present her expertise as a speaker, and is a leader in the community. After 25 years of family practice, she has expanded her interests to include a groundbreaking allergy management program known as Allergy Immunotherapy. We are very pleased and proud to welcome Dr. Susan Debin.
Thank you. Oh, thank you. Well, a few years ago, I went to a conference where they asked a series of questions, and they gave us one of those little machines where you'd plug in your answers, and up on the screen would come our collective answers, telling us how well we did. So one of the kinds of questions they asked us was, how many patients with allergies does the average primary care physician see in a typical week? And the choices they gave us were 5, 15, 25, 50, or 75. So I don't have one of those machines, so you got to shout it out. What do you think the answer was? Take a guess. 75? 15? Who said 25? Okay. Take that man a prize. 25 is the answer. Now, I have to tell you, when they asked that question, it wasn't even on my list. I'm thinking hypertension, diabetes, low back pain, hypercholesterolemia, GYN problems. It wasn't on my radar screen at all, which meant 25 patients were walking into my office every week and walking out undiagnosed and untreated. So we do have some significant problems in allergy management, and it points to the need for evidence-based allergy care. And that's what I'd like to show you here. Oh, up here. They told me to do that. Da-da-da-da-da. Now, I think I'm pointing... Okay, well, we skipped one. Oh, see, I went so fast. I want to tell you what those problems are. Number one is that we really do have an allergy and asthma crisis. Problem number two is that we don't have enough allergists to treat this increasing demand in allergies. Problem number three is that as primary care physicians, we are treating symptoms, not the cause. Problem number four is that patients aren't satisfied with that. We aren't meeting our patients' needs. And problem number five is that this is a huge economic burden. It's a burden to society, economically, and it's a burden to our patients. And problem number six is that as primary care physicians, we just aren't familiar with allergy management and immunotherapy. So let's look at the statistics. 1 in 4 patients have allergies. And that's where we get that number, 25. That's the number of patients the average primary care physician sees. That's 4 to 5 patients every single day. Now, that's 50 million Americans, a whole lot of people with allergies that we aren't taking care of properly. And there's a study that was done that showed that 54% of those people with allergies actually have one or more IgE allergy reactions. So it's probably more than 25%, so whoever said 50%, you probably were right. So allergic disease is the 5th leading chronic disease in the U.S., and it's the 3rd among children under age 18. Interesting statistics. Almost 17 million office visits are attributed to allergic rhinitis. And sinusitis, 18 million. 20 million Americans suffer with asthma. Sinusitis and allergies definitely have a connection. Asthma and sinusitis, 40 to 75% concurrence. Think about the patients that you see. Out of an estimated 10 million asthmatics, more than 70% of them have allergies. This is really an important statistic. Between 1980 and 1994, children under the age of 5 have increased in their asthma rate 160%. So the need for care has increased dramatically. So why do you think they've increased? There's a bunch of theories out there of why that is. One of them may be global warming. We get increased CO2, we get more flowering of the plants, more growth of the plants, the pollen's produced, shorter winters, longer summers, spring and fall, and what do we get? Allergies. Another hypothesis is pollution. I come from near the LA area, and I think back in the 70s, I think it was 70s or 80s, I used to see on TV these air quality alerts, and you'd see this blanket of gray sitting over LA, and they actually had pictures of people in gas masks. You know, the day was coming where we were going to be wearing gas masks, because this increased fossil fuel burning stimulates that faster plant growth, makes it more difficult for our patients to breathe, and so especially in the urban areas, we see more and more of the allergy rise. Genetics, a huge one. If you have one parent with allergies, you have a 30 to 40% chance that you're going to have an allergic child. How many people in this room have allergies? Raise your hand if you do. Yeah. 30 to 40% of the kids are going to have allergies. If both parents have allergies, that risk is going to be 70 to 80% that their child is going to have allergies. This is another one, the clean hypothesis. We're sanitizing ourselves to death. You know, we put that gel on. We don't let our own body's natural immunity even build a response. We're using vaccinations, the broad use of antibiotics, these heavy-duty antibiotics, so that our body isn't even building immunity. And then our kids, they're not outdoors playing anymore. They're in front of the TV and they're playing video games. They're not out there being exposed to those pollens, even building their own natural immunity. And then the other problem is what we as physicians do. We treat the symptoms. You know, our patient comes in, they've got all these 15 lists of their problems. We've got the list of 15 we want to deal with that we're worried about for their health, and then allergies is in there as well. So when they raise the issue, what do? We hand them a pill. We don't treat the cause. So the solution is evidence-based approach. We start by establishing a comprehensive history and physical for allergies, and then we identify and confirm what the allergens are through IgE testing. Once the allergens are identified, we can tell our patients these are the things to avoid. I had a patient the other day that came in and we had done her testing, and we went over the results, and she went home and she didn't know what this tree was, so she got on the internet and she looked it up and she went, "You will not believe it. That's the tree that's sitting in my backyard where my open window is sitting next to." So she learned that she could just close her window and that could make a difference for her. Then we provide pharmacotherapy for the short-term relief. And most important step is go to the cause. Provide that immunotherapy so that they can build the long-term tolerance. So problem number 2, too few allergists to handle that increased allergy demand. And I showed you this statistic, so we'll go to the next. If you look at the numbers here, allergic asthma in 1980 was 6.8 million. It doubled by 1994, and by 2005 it was 22 million. Huge numbers. Now, the supply of allergists is expected to decline, but we're looking at a 35% increase in demand by 2020. So we need to do something to provide that care. The answer isn't to provide more allergists. The answer is primary care physicians. We are the solution to better allergy care. You know, we're the front line of defense. We're the ones that see the patients every day. So what we have to do is we need to teach our primary care physicians how to better identify and diagnose and how to treat those allergies. You want to give them the tools to monitor and to treat the allergies effectively. Now, some people go, well, I don't have the time. I'm too busy. I cannot reorganize my clinic to make this happen. When I looked at doing this, and I started it, the training we did was a half a day. We did it on a Friday. On Monday, we started our therapy, and I incorporated it right into my practice. I didn't hire more staff. I didn't set up special hours. It was just part of the practice that I did. So, primary care physicians not treating the cause. This is Al Allergy. You know, he walks in our office. We don't even have to examine him. We can look at him and know what his problem is. So we do our quick history and physical, and our physical is we look at him. And then we write a prescription, and we give him maybe some steroids. We totally skip identifying the cause, suggesting avoidance, and actually going to the cause. So if you look at normal disease management, we start with something like hypercholesterolemia. We talk to the patient, we find out their history, we find out their family history, and we go, maybe they have high cholesterol. So let's do some testing. I do a VAP test. I identify what their cholesterol level is. I make recommendations. I involve the patient in the care through their diet and their exercise. And when that has failed, then I look to perhaps adding medication. Now that's effective therapy. What do we do with symptom-based treatment? We ask them a couple of questions and we give them the medicine, skipping all the steps in between of evidence-based medicine, and what we end up with is ineffective care. So the solution to symptomatic care is evidence-based allergy care. This was out of the Journal of Family Medicine. Only skin or blood IgE testing can accurately identify those allergens for avoidance and threshold reduction. And I thought this was very interesting. This came out of the Journal of Family Medicine, doctor out of UCLA. He looked at a study in a managed care organization where 2/3 of the patients that were being treated for allergy symptoms actually had no allergies. So what they did is they looked at 244 patients treated with non-sedating antihistamines for allergic rhinitis. They found through specific IgE testing, only 35% of those patients were positive. So it means we're treating a whole lot of patients that don't need to be treated. So effective care is identify if that's the case. And I think this is a very helpful one too. Vasomotor rhinitis versus allergic rhinitis. How do we know which it is? We don't. We have to look at testing to identify what it is. And this one published guidelines for allergic rhinitis. They actually recommend skin or blood testing when the symptoms are persistent or the significant impact on quality of life. I really do think that you have to treat every patient individually, and it's not like there's some rule that they need so many symptoms for so many months before you treat. Look at how it impacts their quality of life. So specific IgE testing should be considered so that you can identify the things that they want to avoid. You want to distinguish between that allergic and non-allergic rhinitis. In doing so, you're going to be able to eliminate that expensive antihistamine that they didn't even need. You're going to be able to select cost-effective medicine for your patient. Now, if a patient is just too complex, they've got peanut allergy, bee sting allergies, that might be a patient that you'll choose to send to the allergist. But what you're going to find when you do this evidence-based approach, there's going to be a whole lot of patients that you're not going to have to send off to the allergist. Now you want to think about that if their symptoms haven't been controlled or they haven't been adequately relieved by the existing therapy that they've had. So problem number 4 is our patients aren't satisfied. Okay? Patients just aren't knowledgeable about their medications. In a study that they did, they found that 42% of the patients were confused about their choices. I get patients all the time thinking they were supposed to take one medicine and stop another, and they're taking the wrong medicine, and they're taking the wrong dose. It's a nightmare when they're taking more than one medication. 59% wish they knew more about their medications. And this is the most amazing one. 83% of the patients thought they should have relief within 30 minutes. Anybody use nasal inhaled steroids know that that's not the case. 55% said symptom relief just didn't last long enough. And 31% overall were not satisfied with their existing allergy treatment. So many patients are taking anywhere from 2 to 4 medications. They can be doing the over-the-counter medications, and they don't even tell you they're doing those. They don't consider those medications because they're over-the-counter. 36% are receiving prescription nasal steroids, and then 22% are getting other medications like Singulair or bronchodilators. So the top 5 reasons why patients don't comply with their medication. The biggest one is lack of symptom relief. You know, they're not getting better. I actually thought the most would be the troublesome side effects. You know, patients really don't like those medications. They don't feel good on them. Or the other one is they won't even try them because they're afraid of the side effects. So patients are not satisfied with symptomatic allergy care. Solution? Evidence-based approach to complete allergy care. Like I said, do your history and physical. Don't leave out that step identifying and confirming their allergies. You do your testing, suggest the avoidance measures. And then short-term pharmacotherapy to help them with their symptoms temporarily. But the key is provide the immunotherapy to build that long-term tolerance. What about the economic impact? Anybody have a guess of how much it costs a year for asthma care? Pick a number. I got another prize. Somebody say a number. If only one person says, you win. 75 what? 30 million? 30 billion? Oh, 60? Okay. Who's 30 billion? Yeah, give them a prize. It actually was 18 billion. 18 billion. 10 billion of it is direct healthcare costs. 8 billion is indirect costs, the loss of productivity with work. But 5 billion of that is medications. $5 billion a year. What a huge impact we can make. In 1996, the estimated expenditures for sinusitis was $5.8 billion. So hundreds of millions of dollars are spent every year on nasal corticosteroids and non-sedating antihistamines for patients that aren't even allergic. We don't know because we haven't tested them. Okay, allergic rhinitis and asthma are 2 of the leading causes of absenteeism due to chronic illness. If you look at children aged 5 to 17, it's almost 15 million school days every year are missed because of asthma. Adults missing work, almost 25 million days a year. Huge impact. Every day, every single day, 40,000 people are going to miss school or work. 30,000 people are going to have an asthma attack. 5,000 are going to end up in the emergency room with asthma. 1,000 will be admitted every single day to the hospital. And 11 people every day die from asthma. And the thing about asthma is that people don't take it seriously. They think, oh, it's mild, I'm okay, I don't have to do anything about it. My own daughter has asthma, and she has rare attacks now, but she lives in LA, I live in Orange County, which is an hour away. She calls me one morning going, Mom, I can't breathe. And I said, honey, get your bronchodilator. I don't know where it is, Mom. So it was so mild, and she never had trouble, that she didn't even know where a bronchodilator was. Well, I told her, you know, you call 911. She said, no, Mom, I'm coming to you. So she got in the car and drove an hour to Orange County. People die from mild asthma. It's serious. Every single day, 11 people die. So the solution on this economic impact? Evidence-based, complete allergy care. You reduce the cost of medications by eliminating the misdiagnosis. You reduce the medication cost by increasing the tolerance through immunotherapy. They aren't going to need those medications. You reduce the amount of ER visits, doctor visits, hospital visits, because you can actually reverse upper respiratory disease. You reduce absenteeism from work, from school, and you eliminate that loss in productivity. Billions of dollars every year. We can make the difference. You know, I went into medicine, and I think we all did, because we really wanted to make a difference. And it's really exciting when I learned about this, that I saw how I can make a difference every single day in my practice. So, PCPs are just unfamiliar with immunotherapy. My husband's a businessman, and his accountant told him one day, I got this primary care doctor. She's a family doctor right here in our community, and she's doing shot therapy for immunotherapy. She is making big bucks. You should tell your wife to do it. So he comes home and he tells me, I think you should do it. Well, this is what I did. I stacked arms. I said, I'm not doing it. I'm not familiar with allergies. I'm not comfortable with it. Subcutaneous therapy is dangerous. People die from it. So it just was something I wasn't going to do. Now, I didn't realize that there was an option, sublingual drops. This whole concern about the liability issue. You know, perhaps people don't do it because they're worried about malpractice. I mean, I was worried. I didn't want to kill anybody. You know, first do no harm. They're just more comfortable referring patients to allergists. I'm actually not comfortable with that. I think I can do a better job than the allergist can. And I give my patients time, and I listen to them. And patients tell me when I send them off to specialists, they spend 5 minutes with them, and they're out the door. So I think I can do a lot more for them. They're under the impression that it's just too difficult. When I was about 5 years, I've been 25 years in practice. When I was about 5 years in practice, we were going to make a practice brochure. So we worked on the brochure, and we rewrote it and reread it, didn't like it, rewrote it again, reread it, didn't like it, did it again. It's now 25 years later. I still do not have a practice brochure. I have difficulty. You know, it's got to be perfect, it's got to be right, and I got to know everything before I say yes to it. So when it came to this sublingual immunotherapy, first thing I wanted to do was know the science behind it, and I got the reports in the literature, and I read it, and I'm going, this looks good. This looks like this will be good for my patients. And so then I had a presentation, and I listened to the presentation, and I don't know, there was something in my gut that said, this is right. This is the right thing for my patients, and it's the right thing for my practice. And I just took this leap of faith and just said, yes, I'm going to do it. And I will tell you, it is probably the best thing I have done in the 25 years of my practice. It is really inspiring to see what's happening with our patients. And the economic health of my practice. I mean, it's a win-win here. People think they don't have enough staff to provide that immunotherapy. I did not hire a single extra person. We all do it right in the practice. I closed my office for a half a day on a Friday. We had a presentation about allergies. Every single staff person was trained in how to mix the allergens Even though my receptionist isn't even going to touch them, that's not what she's going to do. I made sure everybody in the practice understood what we were doing. And I think that really made a difference in the success that we've had. And many just think it's too complex to provide. I tell you, this was the easiest thing I have ever done, the easiest. Or they think that it's not safe or proven. Well, it's been around for 100 years. I'll show you some literature. So the key is education. Primary care physicians can do this. They just have to be educated. And it's not difficult. So, immunotherapy, truly, been around almost 100 years. It is the only potential cure at this point for environmental allergy. And you want to consider it when avoidance can't be achieved, or when medications have failed, or when the cost of medications are exceeding the cost of immunotherapy. So the concept is that we can teach our immune system not to overreact to the allergens. So the dust mites and the molds and the dander and the pollens, we actually can educate our immune system. So it starts by introducing into our immune system diluted doses of the allergen, and it can be either by shot or by sublingual. And then gradually that concentration is increased so that our body learns to ignore it and learns that it's a harmless substance that isn't going to hurt the body. So that's the desensitization that occurs. So everybody has an allergy threshold, and if you don't reach that threshold, you don't have symptoms. So you may be allergic and you're getting allergens at you, but they're not to the level that cause you to have symptoms. But then that allergy load becomes too great and symptoms occur. Through avoidance, we can reduce and restore that subclinical load. So allergen 1 and allergen 2 we were able to avoid. But you know, I got a cat and they sleep with me every night, and that's like my baby, and I'm not getting rid of them. Patients tell us that all the time. Okay? So what they can't avoid, we may want to desensitize them. So when you add immunotherapy, you actually raise the threshold. They become tolerant, and they can be exposed to more and more things, and they don't react to it. So it's going to be effective when antigens are of specific sensitivity, and you do that through your IgE testing. They have to have adequate potency to trigger that immune tolerance. They have to be given frequently enough to build the tolerance, and they have to be given long enough to maintain that immune tolerance, and that can take usually 3 to 5 years. So the changes that you're going to see, a decrease in the seasonal, total, and specific IgE. You're going to see an increase in those blocking IgG antibodies, a decrease in the eosinophilic chemotactic factors, and a decrease in the basophil histamine release. So patients say, well, how soon am I going to expect to see something? With shot immunotherapy, you know, it's often a year before people are even recognizing that anything is different. With the sublingual therapy, I did this thinking, if this is as good as shots, this will be great, because my patients aren't going to have to drive to the doctor twice a week and get shots. They're going to be able to do this at home. What absolutely blew me away was how quickly the response came with sublingual therapy. In a month, patients were seeing a difference. By 3 months, dramatic changes. So usually symptoms decrease at that 4 to 6 week. I have patients telling me, for the first time in 10 years, I can breathe through my right nostril. I can smell things again. A patient with urinary stress incontinence because she was sneezing for all of her allergies. We treated her allergies, her stress incontinence went away. No more problems there. I have a PA who has big-time allergies. She used eye drops for her allergic conjunctivitis, a nasal steroid for her congestion, a non-sedating antihistamine. She was on Singulair. She had asthma such that she was chronically on Advair, and then on occasion used her albuterol bronchodilator. 6 medications. She started sublingual therapy. At a month, she wasn't using her eye drops anymore. At 2 months, she was off her antihistamine and her nasal steroid. At 3 months, no more Advair, no more Singulair. The only thing she used was saline nasal irrigation. Dramatic, in 3 months. So clinically what we see is children with asthma and allergic rhinitis, you get a reduction in the sensitivities and in the development of the new allergens. They feel better. Now, my daughter with asthma, she rarely has asthma. In fact, I don't remember. It was a long time ago when this episode happened. But she was tired all the time. She just had this fatigue, and that's one of the things allergies will do, is they just wear you down. And when we put her on the allergy drops, it was amazing, the improvement in her energy level. My son, I have 3 children. My son has allergies, my daughter does, and then the other one doesn't. My son didn't believe he had allergies. When I said, I think you should be using these drops, he says, I don't have allergies. And I said, Ryan, that snorting you do is allergies. And his wife's going, yes. So I left the drops for him. He didn't do it. A couple months later, I asked him, did you try the drops? No, but I'm going to. I'll try it. And then I didn't ask him anymore because I thought, well, when he's ready, he'll do it. And then he says to me, Mom, those drops really work. And this is a guy who said, I don't have allergies. Now, this is an important thing. Immunotherapy can slow that allergic march. When children are born and they have that atopic dermatitis, the eczema, that is the marching orders to asthma. 40% of the kids that have allergic dermatitis end up with asthma by age 4. And we can actually slow that down, stop it, and reverse it. So I think it's really important to catch those children early and stop that progression to asthma. So they can present as skin rashes, colic, another allergic symptom, the ear infections, the otitis media. All these are underlying allergic inflammation. And many children are born with it. They've got the genetic predisposition in utero. So they start with the allergic dermatitis, they get the otitis media, the colic, and then pretty soon the allergic rhinitis, and then they end up with asthma. We can prevent that.
Check two.
No, that's too long for you to read. Let's go to the next one. Let me just show you. In terms
Check
of
1, 2,
food
1, 2, 3, check.
they start out high. With time, they do diminish. The inhaled allergens, they start out slow and they increase. So that child that's born with allergic atopic dermatitis, the next thing they're going to show up with,
Check
GI
2.
colic. Next thing is
Check.
the
Check
recurrent
1, 2.
otitis media.
1, 2, 3.
Then they get
Check
the
2,
allergic
2, 2,
rhinitis,
2,
and bingo, there's their asthma. So here we have the atopic dermatitis, and here we have the GI symptoms. Now, if you see here, at around 3 to 4, they start showing up with their asthma. So if we can get them early over here, there it is, if we can get them here before, say, age 4, we can even stop that development from occurring. So our goal is... Oh, it went so fast. I want you to see where we want to intervene here, if I can. Let me see. Let's go back. Here's where we want to catch them. We want to try to give them that sublingual immunotherapy early on. And This is safe to give in infants. You can give this at 6 months of age, even 3 months of age. What you need is a parent who is willing to make sure that it happens. Now, allergic reactions to certain food. It's known as oral allergy syndrome, OAS. You see people with hay fever also having reactions to certain foods like fruits and nuts and vegetables. And what happens is the food allergy is when our immune system mistakes the food protein as the allergic protein, as the pollen protein. So it's getting confused and it's reacting to the food when it's the pollen allergy that's the allergy. So what we found is that as we treat the inhaled allergens, the cross reaction that you get to reduce the food allergies is significant. So it's pollen food allergy, it's what it's known as, and you're going to treat it like you would treat any allergy with medication, avoidance, and immunotherapy. Symptoms. If somebody eats something and they get this OAS, it can be sudden, acute, in minutes after they eat the food. They'll get the itchy throat, the burning lips, the burning in the mouth, eyes itching and burning, nose running, skin breaking out, swelling of the lips and tongue, the throat getting closed down tight. If the food is swallowed, then they can even get GI symptoms, acute diarrhea, cramping, abdominal pain. So the treatment, number one, is you want to do the IgE testing to identify the environmental and the food allergies. Now, some people will get the delayed reaction to food. So you think about the patient with IBS. Those patients may not be having the acute reaction. They may be having the delayed reaction, and that's where the IgG testing that Immunolabs does can actually identify. So if I have a patient who's negative on IgE, doesn't mean that they don't have the food allergies. Do the next step. Look at their IgG. So you identify the foods. It's what they were talking about earlier today. It is helping them to avoid those foods. And I love that Immunolabs has the program to help your patients avoid those foods. Because that's the challenge. It's the challenge for the individual and for the family. Now, peeling or cooking the foods sometimes can eliminate those allergens, like in apples, but not in others. Celery and strawberries, it doesn't work. Antihistamines can relieve the immediate symptoms. You want to make sure your patient's got an EpiPen if they're having those kind of reactions. And then immunotherapy to improve or cure the oral allergy syndrome. So allergies to certain pollens are associated with these oral allergy syndrome to certain foods. And it doesn't mean that all sufferers from pollen allergy will experience adverse reactions from all or any of the foods, but you don't know if you don't test. The reactions can begin with one type of food and then later others develop. And it can be to one or more foods in any given category, but it doesn't mean that the patient's going to be allergic to the entire group. You can help to reduce it by cooking it, using canned, pasteurized, or frozen food because it denatures the protein. And when the protein's denatured, then you don't get the cross-reactivity. So these are, this is on our card that you can pick up. This wasn't on the original one, so stop by the booth at Allergy America and they'll give you this new, because it'll give you all of these things that when your patient has allergies to birch pollen, these are the foods that potentially cross-react. It's amazing, look at all of that. So how long do the effects of immunotherapy last? In studies that they've done in patients that have had immunotherapy for 3 years, and then one group continued the immunotherapy for 6 years, the other group got placebo injections, and both groups had equal clinical efficacy after 6 years. So you do your therapy, 6 years out, we have studies showing persistence of good clinical effects. So it's not like they do this and they have to do it forever. So how do you start with immunotherapy? So the antigens of demonstrated sensitivity are identified. That's your IgE testing. The patient should avoid those allergens when possible, and you educate them on that. You want to give them medication to relieve symptoms if the symptoms are bad enough, and then you want to start immunotherapy. You have the option of allergy shots or sublingual immunotherapy. So the goal is to reach maintenance. You want to get the highest tolerated dose that's going to produce that immune tolerance. The higher the dose, the better the chance of controlling the symptoms. The higher the dose, the less medication your patients are going to need. And the higher the dose, the better you have as a chance for cure. So compliance is critical. Studies have shown that individuals that did shot therapy, they're doing biweekly or weekly shots. At 1 year, only 30 to 40% of those patients are still doing immunotherapy. It's not easy. It's not easy to go to the doctor twice a week. With drop therapy, it's done at home. And they start daily for 3 months, and after the 3 months, they're on a biweekly maintenance, all at home. Studies show 90% of the patients at 1 year are still doing their immunotherapy. If you don't do it, it isn't going to work. Immunotherapy requires that they maintain doing the allergen. You want to review with them the compliance to their avoidance techniques, and then you want to review any medications for short-term relief. But what you're going to find is they need less and less medication. So the risk factors for shot immunotherapy, these are the reasons why I didn't want to do it. Patients with poorly or systemic reactions or poorly controlled asthma, there's dangers in that. That highly allergic patient, there's going to be risks with the shot. Every time you introduce a new dose of the antigen, there's a risk of an anaphylactic reaction. I worry every time I give a shot in my office for anything, if it's an antibiotic, if it's even their vaccines, I worry, is my nurse drawing that up correctly? And when you're giving immunotherapy and anaphylaxis is the potential reaction, that scares me. So injections during the height of pollen season can be risky. The other thing is the patient has to stay there. Once they go and get that shot, they got to hang around. Again, more time away from school and work. Not wise to use with patients on beta blockers. You can't use it in children under 5.5, and you can't use it in pregnant women. And with patients with a history of anaphylaxis. These factors just don't apply to the allergy drops. That's the beauty of the drops. So the clinical effects that you see, symptoms are reduced. Associated symptoms, my patient with the stress incontinence or the patient's getting sinusitis, they are not going to be getting sick all the time. It's amazing how much healthier they are. Reduction in their medication use. Reduction in the absenteeism because of their allergies. Just better overall quality of life, and that's what we're about. So why do patients stop allergy shots? It's just not convenient. They got to leave work or school, drive to the place, under the doctor's supervision, get their shot, sit there and wait 20 minutes, watching to see if a reaction will happen, and then returning home or back to work or school. The cost of immunotherapy, you think about it, they have to pay a copay every time they go get one of those shots. Usually copays are about $20. They're getting biweekly shots, $40 a week, $160 a month. They're paying just in their copay for their immunotherapy. The risk of those reactions, like anaphylaxis, and I think a big thing is the impression that it's not working fast enough. They just don't see response. And, we are a I want it now society. And it's so nice that sublingual, they get it now. And the limiting factors in shots. There's just a lot of people that aren't candidates for shot therapy. So the sublingual, not the problem. So the allergy drop treatment is similar to shots. It delivers those increasingly higher doses of physician-prescribed, FDA-approved antigens that over time builds the patient's tolerance. The difference is they're placed under the tongue, and they work by being absorbed through specialized cells under the tongue that provide a friendlier, just more effective route for desensitization. And they're optimal in those patients that are at high risk. And in our practice, what we do is they start the drops, they build up their immune system over 3 months. At 3 months, they're on maintenance, and then they go to twice a week. And they do it all at home. Now, I told you it's been around for over 100 years. Before 1900s, they were using tincture of fresh flowers to treat hay fever. And as you go through the century here and see, in the 1900s, they were using flowers and pollen for ragweed. In 1990, they were trying to treat poison ivy by creating immunotherapy for it for the workers. In 1927, high doses of ragweed extract for nasal symptoms. In 1940, they were using pollen extracts. Then, sterile instruments came along, and this injection was viewed as high-tech. FDA approves the allergy injections, and all of this sublingual therapy, all these drop therapies, just go into hibernation. In 1998, this is after FDA-approved injection therapy, the World Health Organization determines that sublingual immunotherapy is a viable alternative to shots. And in 2003, the Cochrane Review, this is a world-renowned organization that looks at different treatments that are available and determined that treatment with sublingual immunotherapy is a safe therapy, reducing the symptoms and reducing the need for medications for allergic rhinitis. Now, it's expected in 2010 that the FDA will approve that third and final test on sublingual immunotherapy. And in truth, I wish they wouldn't, because as soon as it's approved, insurance will cover it, and then they will not pay you anything for it. I give a patient their Adacil, their diphtheria, tetanus, pertussis vaccine, costs me $31. Insurance pays me $28. So I get paid less than it costs me to give it, plus my nurse's time, plus the syringe and the needle. You know? So I hope they never pass it. So, why don't primary care physicians use sublingual immunotherapy? Well, what happened in Europe, they're doing it. They didn't stop doing it. You look at France, Italy, and Great Britain, they are still doing sublingual immunotherapy. In the U.S., allergists dismissed it as quackery. No, I don't blame them, because they make their bread and butter are their shots. If they don't give their shots, that's really the basis of their practice. So the economic reason, they're just going to lose that income if they don't give the allergy shots. The other is survival. If the primary care physician does it, what are we going to send them to the allergist for? And another one is the question of proof. There are studies in Europe that show this works. We've got the World Health Organization that says it works. We've got the Cochrane Review that says it works. A big one is rivalry. When I was chair of the Department of Family Practice at our hospital, we had a turf war over primary care physicians assisting in laparoscopic cholecystectomies. Anybody assist in laparoscopic cholecystectomies? Well, I got to tell you, what you do is you hold the instrument and you turn a knob. We fought the surgeons for 2 years to have the right to do this because that was their turf. So of course they're not going to give it up. They don't want to give up their turf. So So the Joint Task Force for the American Academy of Allergy and Immunology, this is the statement they say. Despite evidence that sublingual immunotherapy is effective, which they say it is, many questions remain unanswered, including effective dose, treatment schedules, and duration of treatment. Sublingual immunotherapy does appear to be associated with few serious side effects. Well, with universal serum, it's uncovered the effective dose, treatment schedule, and duration. So, off-label use of sublingual immunotherapy. FDA-approved allergens are produced in an FDA-approved lab and are sanctioned by the FDA for injection therapy. The same FDA-approved allergens are produced at the same FDA-approved laboratory, but they haven't been sanctioned by the FDA for sublingual use yet. Like I say, it's expected at 2010 that they will be. Insurance companies still consider slit therapy experimental and so not yet reimbursable. So this is a therapy that you offer your patient that they pay cash for. It's not new. I just showed you 100 years. It's not experimental. It's not novel. The true definition of sublingual immunotherapy is that it is alternative immunotherapy solution. So the advantages, they're clear. Safety profile allows us to treat a whole bunch more patients. Kids under 5 can be treated. Pregnant women can be treated. Our patients that are on beta blockers, that have severe asthma, that have hypertension can be treated. Even those with severe anaphylaxis. I have a little boy that his parents took him down to South County to be tested by this big-time allergist, and in his skin testing that they did, he had an anaphylactic reaction with the skin testing and had to have epinephrine just with the skin testing. So they were real nervous about the shots, and I told them, you know, hey, we have sublingual immunotherapy here. So they started him on the drops. This little boy couldn't play outside, couldn't do sports, because if he got in the grass, he couldn't breathe. He's now out in the fields playing with no reaction. Lower costs to the patients. I mean, this is a big thing. Fewer office visits, fewer co-pays just mean less out-of-pocket dollars for the patient. And it's not just for the therapy. They're not getting sick. They're not ending back up in the doctor's office with their allergic rhinitis, their sinusitis, their bronchitis, their asthma. Fewer days off work and school, so you have more productivity. Fewer visits, less travel costs. Okay? No question on that one. Less medications to buy for allergy symptoms. So I got, before I started doing my sublingual drops, my grandbaby was being born, and we went back to Boston, and I had never had a reaction, and I got allergic conjunctivitis so bad my eyes were swollen shut. All I wanted to do was go home, and this is my grandbaby being born. I went and got allergy drops. It cost me $100. They didn't work. My eyes were still swollen shut. I got the steroid drops, another $100. So I went through $200 worth of medications and almost missed the birth of my grandbaby because I didn't have these allergy drops. Since I've been doing the allergy drops, went back to Boston, no reactions. More convenient for our patients. They can take these allergy drops anywhere. At home, when they're traveling, you know, when they go on vacation, they miss their injections, they can't build the immune tolerance. Less need for additional medications. Serum works for multiple allergy-associated issues. Fewer office visits. Just more healthier days. Your patients are going to feel better faster and longer. Let's skip over these. I want to get to how you do this. I told you about the World Health Organization and the Cochrane collaboration. Okay, the safety profile, there's no question it's superior in terms of safety. 3 times less systemic reactions with sublingual immunotherapy. There has never, ever been an anaphylactic reaction recorded in the 60 years of sublingual immunotherapy. 33 deaths have been reported from subcutaneous immunotherapy. Patient compliance, 50 to 70% of those patients have stopped doing the shots by 1 year. 90% are still doing their immunotherapy at 1 year with the sublingual drops. These are some studies that just show the efficacy and lack of risks and side effects. That'll all be in your, just the link between allergy and asthma. Again, when you treat the allergy, you stop the allergic march. Let's keep going. So I want to get to... this is just a meta-analysis of 24 studies that were done looking at 900 asthmatics. They found that allergy immunotherapy was effective in 71% of the studies. So they had reduced symptoms, reduced lung inflammation, reduced need for medication, and improved lung function. So you have two types of allergy drops. You have allergen-specific serum that's designed like the shots that have the specific antigens in what those patients are high in IgE for. It does require the IgE testing, and they get a customized mixed antigen. It's shipped pre-mixed to the physician's office, and they build the tolerance just to those specific antigens that they're reacting to at the time. And they usually get a 6-month supply. Now, universal serum, this is a patent-pending comprehensive mix. This is the kind that I use in my practice. It has over 70 antigens, and then by the time you have the cross-reaction and all with the foods and all, it's up to 170 that you're protecting your patient against. It's a broad-spectrum, multi-regional. See, I went to Boston. I wasn't being protected by any kind of thing locally, but it even worked for me in Boston. Universal serum is standardized. All your treatments get the same thing, so you're not risking, oh, did they get the right one? Everybody gets the same serum. It's got all of the 70 antigens in it. It requires IgE testing initially and then annually to evaluate from year to year. And there, I just want to show you what they look like. These are the ones that we're getting right now. They come packaged like this. We mix them in our office. I'll show you how we mix them. This is what the patient gets, and they also get a little schedule that they write down each day what they've done so they know they didn't miss a day. They're going to be actually switched. These are the new kits that they have. But basically, we do this in our office. My staff mixes these and makes these in the office. And you look at the most dilute one here. This is bottle number 1. It looks like clear. As they increase and get to maintenance, as you have more of the antigen there, you can see it's kind of an amber color. So it's increasing doses of the antigen. And they're broken down into 12-week supplies. They get 3 months at a time. Selecting your patient, does it compromise their quality of life? Do they have any of the symptoms that might warrant them to be treated? The children with the dermatitis and eczema, so they don't march on to asthma. Those patients that you see with frequent sinusitis, throat infections, ear infections, what we did to try to identify the patients that were potentially candidates for this is we went back to our computer system and pulled up those patients with those diagnoses, and we sent a letter to them telling them this was available to them. Severe eye irritation, excessive fatigue. Don't forget fatigue. That's often allergies. That persistent postnasal drip. I had a patient that 8 months had a cough. We had worked her up with a CAT scan, with a bronchoscopy. We did an endoscopy, treated her for reflux. Nothing worked. Even the allergy medications didn't work. I put her on sublingual drops. In 1 month time, her cough was gone and never came back. Oh, migraines. You know, the whole food allergy thing that they talked about with the allergic reaction maybe being a migraine source. So there's a whole bunch of patients that may be candidates for this. And I don't use this criteria if they have symptoms greater than 3 months a year. It's not about how long they have it, it's how it's affecting their life. Anyone with symptoms most of the year, my goodness, they should be a candidate. No one who's tested will not be treated. It's not about their response. They can have a low response and have severe allergy symptoms. And then I have people who have, 7s and 9s, and their symptoms aren't as severe. So it's not about the degree of that number of response that we get. So, selecting your patient. It's the womb to tomb. Low-dose universal serum is safe for children at a few months of age. Parents have to be responsible to make sure the kids get the treatment. In the elderly patient, they get confused about their medications, so you really need someone making sure that they're getting their medications properly. A lot of times what I'll do is, I'll tell a family member, you make sure that they're getting their medication correctly, put it in the little containers. With the drops, I make sure the family does it if the elderly is having trouble. I have a 73-year-old patient. She was foggy-headed. She was on maintenance, and she said, I'm just foggy-headed. So what we did is we calculated she was getting 14 drops twice a week. That's 28 drops a week. We reduced her back to 21 drops a week, and instead of giving her a big bolus, we gave her 3 drops every single day as her maintenance, and the foggy head went away. Pregnant patients. Really, at this point, you can treat pregnant patients with the low-dose universal serum. No risk. And this is just showing that doing the blood testing, with these third-generation testings, you can get accurate results for specific IgE and IgG. Skin testing, it may require confirmation in some patients with skin testing. If they have a low score and yet they have persistent symptoms, you might think about doing skin testing. If a patient isn't responding after 2 to 3 months, because they do respond. I've had 2 patients who haven't, and both of them were about compliance. One was a teenage boy, and I just saw he wasn't going to be consistent, and I told his mom, don't do this. He's not going to be consistent. The other was a young college student, and she had just gone off to her first year of college, and she just didn't have her act together to be consistent with using it. So it wasn't a failure. That was compliance. But, very few aren't compliant because it's so easy to do. So I do not handle patients with bee sting, venom, or peanut allergy. I send them to the allergy specialist. So avoidance. The first step is you've got to talk to your patients about avoidance, and so I think what Immunolabs has here is great to help you with that. Avoiding the specific foods to reduce the food allergies, frequent cleaning, vacuuming, people taking up their carpeting out of their bathroom, putting in hardwood floors, covering their mattress, their box springs, covering their pillows and their blankets. And in truth, I'll tell you, I didn't tell patients to cover their blanket. I told them to do the rest of it in terms of avoidance. And I was just recently at an allergy seminar, and the allergist said, yes, they need to cover their blanket too. Of course. Sometimes it's just too difficult to avoid all these things. I had a patient that came back. She was back east. She came back we have the Santa Ana winds, and when the Santa Ana winds come up, allergies go crazy. We just see patients, running to our office. She said, I was dreading coming back because I heard that the Santa Ana winds were up, and she was on her immunotherapy. She said, I came back and nothing happened. She was fine. And these are the different pharmacotherapies for short-term care. So you identify the allergen, you do the avoidance measures, you provide pharmacotherapy when necessary. If symptoms persist, do your allergy drops. I don't say do all those things. Do allergy drops too. It's about cure. You don't want to just Band-Aid them. So you give them the 8 dilution starter pack. The out-of-pocket cost is often way less than going to their allergy specialist. So their initial visit, they come in, we see them, it's a 30-minute visit. We determine whether they have allergies. We do the history and physical. we say, yes, it looks like you do have allergies. Let's assess them with a questionnaire. We have a simple questionnaire they fill out, and it's very helpful because then when they come back, they fill out the questionnaire again. And I can just look at the paper and see their scores have dropped. You identify the patient as an allergy candidate. You do the skin testing. You do the spirometry, check their lung function. You see them back in 2 weeks. You do a follow-up visit. You go over the test results with them. You talk about avoidance. You do the short-term medication when you need to, and you start them on the universal drops. I have my nurse put the first set of drops under their tongue in the office so they see there's nothing to it. You instruct them to hold the serum under the tongue to allow the proper absorption to occur. Have them not have any fluids for 5 minutes after they do the drops. On visit 3, that's at 4 weeks later, we look and see how they're doing. The reason I have them come back then is because I want to make sure that they've got the routine down, that they're doing it. If you don't do that 4-week follow-up, you may miss patients, they just didn't do it. So I think that's an important step. You do assess their progress, see if they need any more medication, see what their spirometry is then. So then they come back 8 weeks later, they are now to their maintenance dose, and that's where you just hear great results. Everybody's happy. Of course they want their maintenance therapy. And then we see them every 3 months after that. Again, each time we assess how they're doing, see if they need medication, and we find they don't need medications anymore. All they need is their immunotherapy. Then annually we do their IgE testing. Now, just so you'll see how simple this is, this comes in as a packet. My staff does the mixing. It takes them minutes to do. They get a universal serum in a matrix diluent. We get 8 bottles. Number 8 is the maintenance bottle. We get all 7 bottles. They take 8 mLs and put it into bottle number 8. Then they put 4 mLs in each of the other bottles. And then they put 2 mLs into the maintenance bottle. And that's the universal serum. That's going to be the strongest one. That's their maintenance one. Then they take 1 ml out of that and put it into bottle number 7. They take 1 ml out of bottle number 7 and put it into bottle number 6, and then into number 5. And you just keep diluting it down so that when they get to bottle 1, that is the most dilute serum. So the patient starts with dropper 1. They start out at 2 drops a day, then they go the next day to 3 drops, and they have a little schedule. They just write it down so they don't forget any. When they finish the first 10 days with bottle 1, they move to bottle 2, and it's all written out for them what to do. It is just so simple. They start with 2 drops. They drop back. They start with 2 drops of bottle number 2, and they build up again, and then they go to bottle 3. And they build this down. So here's the schedule with each of their bottles, dropper 1, 2, 3, all the way up to maintenance. When they get to maintenance, they are doing twice a week, 14 drops. So if somebody, here we go. If somebody stops their medication, first I'll tell you toddlers. They go to their number 8 bottle, they stop at 10 drops and go to biweekly. Infants stop at 7 drops and go to biweekly. If they stop their therapy, I went on a 3-month trip and I forgot my bottle. If they are 1 to 4 weeks off, you just continue them as they were, twice a week, 14 drops. If they restart after 4 to 12 weeks, you go back to bottle 8, half dose, so they would start at the 7-drop mark on their number 8, and they would just progress from there. And then if they've been off for more than 3 months, they just go back to bottle number 8, and they do the whole build-up again. Now, I just want to tell you this part. My husband, when he was trying to convince me to do these shots, he says, Susan, you need to work smarter, not harder. I get up in the morning, work all day, do my calls at the end of the night, come home with a basket of charts I'm working on. Midnight, I go to bed and start all over again. He says, you need to work smarter, not harder. So when I was introduced to this sublingual immunotherapy, the thing they said to me was, Our mantra is work smarter, not harder. So it was like, okay, I guess there is something to this. Look at the business side of this. Better medicine is better business. Statistically, 1 in 4 patients have allergies. So an average business day, 20 patients, equals to 5 allergy patients a day. Let's be conservative and say you have 1 allergy patient a day at $200 per box per 3-month serum. The cost is $80. Your profit on that 1 patient is $120. Okay? 5 days a week, 20 patients per month, 2,400 times the 3 months. In your first quarter, your profit is $7,200. That doesn't count your office visits and your skin testing and your spirometry. That's just the serum profit. So you continue the same patient load, and like I said, I've only had 2 patients drop out. Continue the same patient load. 1 patient a day for the 3 months is another $7,200 in new patients, plus your first quarter patients are returning, another $7,200 for them. Your second quarter is $14,400. Continue that same patient load, 1 per day and 3 in the 6-month return visits, $7,200 on those new patients in that quarter, $14,400 on those return patients, $21,600 in your third quarter. Okay, now we're at the 4th quarter, 1 patient a day. Those that are returning 3, 6, and 9 month, we have $7,200 in new patients and $21,600 in our returning patients, $28,800. That is a total of $72,000 in profit to your practice, not counting office visits or anything else. That is your profit. So evidence-based allergy care and allergy drops. Allergy cases are increasing and specialists are declining. Evidence-based allergy care with sublingual immunotherapy can reduce and stop that progression of allergies to asthma. Patients aren't happy with that treat 'em and treat 'em kind of idea. They want to be cured. Evidence-based allergy care with sublingual immunotherapy can save billions of dollars to society and money to our patients. It's safe, it's effective, it's convenient, it's cost-effective alternative to allergy thoughts, and every primary care physician can do it. Thank you.